Good evening and welcome to this Rural Health satellite broadcast on childhood immunisation. I'm Bruce Minges and I'm a GP in Armidale, New South Wales and Chairman of the New England Division of General Practice. I'm grateful for the opportunity to chair this evening's programme, which has been made possible by sponsorship from the Commonwealth Department of Human Services and Health. With the rapid expansion of this network, it is also my privilege to welcome some 78 new hospitals who are joining us tonight for the very first time. These are too many to mention by name, but we would like to acknowledge the assistance of the local hospital coordinators and the rural divisions of general practice for getting these new sites up and running in Tasmania, the Northern Territory, South Australia, Victoria and New South Wales. This programme is being produced with the assistance from the Australian Paediatric Review Training Programme, which has developed the pre- and post-satellite quizzes. Many of you have elected to complete these. The post-satellite quiz will be forwarded to you later. Approval has been obtained from the RACGP Quality Assurance and Continuing Education Programme for doctors who complete both quizzes and attend tonight's programme to receive a total of 9 CME points. For doctors who are attending simply tonight's programme, you'll be credited with 4 CME points. Approval has been obtained from the College of Physicians and for 4 MOPS points for paediatricians and physicians who attend this programme. We, as rural GPs and nurses, tend to be more a part of the community in which we live and work than our metropolitan colleagues. We are responsible for the care of our patients throughout their pregnancies and are usually present at the delivery of their children. Offering our patients and their children protection against disease by immunisation is a vital part of the service we provide to our communities. Apart from the provision of clean drinking water, immunisation against infectious disease has saved more lives and prevented more suffering than any other single public health measure. Technological advances provide us with more and better vaccines to defend our patients effectively against more diseases. A baby born in 1995 may expect to receive up to 25 doses of vaccine against 9 different diseases on 5 different occasions in the first 18 months of life. The increasing and often bewildering complexity of the immunisation schedule may, however, mitigate against the delivery of the vaccine itself. Maintenance of the cold chain, informed consent and confusion over valid and non-valid contraindications for immunisation are just some of the many factors that may provide barriers to achieving the national target of 95% immunisation coverage by the year 2000. I hope this evening that the panel will be able to help us, as providers of immunisation, to break down some of these barriers. Let me introduce the panel members to you. Dr. Margaret Burgess.
Good
Margaret
evening.
is from the Royal Alexandra Hospital for Children in Camperdown in Sydney. Dr. Robert Hall. Dr. Robert Hall worked in Outback Australia for some 4 years in the early 1980s and is now at the National Centre for Epidemiology and Population Health at the Australian National University in Canberra.
Good evening.
And finally, Associate Professor Desley Hegney from the School of Nursing, University of Southern Queensland in Toowoomba.
Hi.
Now, let's get underway. We've asked Robert to provide us with an overview and to get us up to date with the latest recommendations for childhood immunisation. Robert.
Thanks, Bruce. Tonight we're talking about immunisation, and what I'd like to do is to go through some of the changes that have occurred recently to the schedule and to some of the new recommendations from the National Health and Medical Research Council. The NHMRC published a new edition of the Immunisation Procedures book late last year, and these are some of the things that I'll be talking about tonight. There have been new changes to the schedule. There are changes to immunisation procedures. The changes to the schedule I want to talk about are introduction of new vaccines, introduction of new times for giving the vaccines, and to discuss some of the reasons why we've made these changes. I also want to talk about the procedures dealing with the prevention of some of the minor adverse events that may follow immunisation, and about discussing these issues with parents. Immunisation is a cornerstone of modern public health. It provides effective, high-level protection to children against many infectious diseases and is a remarkably safe procedure. I'd like to show you what's happened in the last few years, where we've had about 10,000 cases each year in the last 2 years of measles, of whooping cough and of rubella. As you can see, there's been a great increase since about 1987 in the numbers of vaccine-preventable diseases in the community. And further, we know that about 10% of the cases of rubella occurred in women of childbearing years. We know from the Australian Paediatric Surveillance Unit that there have now been several cases of congenital rubella syndrome reported in the last couple of years. But the news isn't all bad. If we look at what's happened with Hib, Haemophilus influenzae type B immunisation was introduced on a mass scale in mid-1993. And as you can see, there's been a dramatic reduction in the number of cases of Hib reported since the introduction of that vaccine. Before the vaccine was introduced, there were around about 700 cases a year, and there's been a reduction of at least 70%, which looks as though it's ongoing. But we have a long way to go. The last time that there was a national assessment of the level of coverage of immunisation in Australia was in 1989-90, where the Australian Bureau of Statistics measured the level of coverage against vaccine-preventable diseases as 53% of children under the age of 6. If you adopt a more stringent standard, just looking at children who could prove their immunisation status on the basis of records, that number dropped down to 37%.
Rob, if I could interrupt there, that seems a big discrepancy between those two figures of uptake.
Well, it certainly is, and this is one of the major problems that we've found in Australia, that record verification of immunisation status is difficult.
Rob, if I could just mention the immunisation register that we established at Armidale. In fact, we found that only in research that I did myself for my honours, I found that in fact only 37% of people actually had records, and when we introduced the reminder system, we found that went up originally to about 96%, I think it was, Bruce, and then it came down and stabilised around 82%. So, you know, there are ways and means of a simple thing like a reminder system, in fact, increasing uptake.
So I think that shows that there are a number of things that we can do from a kind of systematic perspective to improve our rates. But what's new in the Immunisation Procedures Handbook of the National Health and Medical Research Council? Well, the first thing is the new vaccine, the Hib vaccine. The National Health and Medical Research Council recommends that all children under the age of 5 should receive a full course of Hib vaccine. And as we've seen before, that this has already produced a gratifying response in the reduction of Hib disease. There are new schedules. The current schedule is that children should receive DTP or triple antigen vaccine, oral polio vaccine and Hib vaccine at the ages of 2, 4 and 6 months. This means that children will need to receive at least 2 injections on the same occasion in the first 6 months of life. As children get older, then there are further changes to the schedule. At the age of 12 months is the first dose of MMR vaccine. At 18 months is DTP, triple antigen vaccine, and the final dose of Hib vaccine. As children go to school, they become at particular risk of spread of disease, and so we have introduced a 5th dose of DTP or triple antigen vaccine. The reason that we've done this is that we have not been able to control pertussis with the previous schedule of only 4 doses of vaccine, and we have followed the US and Canadian experience by introducing this 5th dose, which they have found increases control quite markedly. There are new contraindications to the vaccines. We've simplified the contraindications quite markedly. There are now very few absolute contraindications to the use of DTP or triple antigen vaccine. We've introduced a simplified method of pre-immunisation assessment, looking for conditions which may defer or may preclude the use of various vaccines. And you see on your screen the current recommendations which are found in the Immunisation Procedures Handbook. We are now recommending as a routine that all children should receive a dose of paracetamol to prevent the very common minor fever which occurs after the use of DTP vaccine, and that we recommend that this also be explained to parents with the use of MMR vaccine. About 10% of children will develop a mild fever about 7 to 10 days after the administration of MMR vaccine. It's important to explain to parents the minor problems that may occur after immunisation. In your site kit, there is a reproduction of the recommended sheet that should be given to parents or discussed with parents before their children go home, explaining what they should do for minor or other reactions to immunisation. Basically, it explains local reactions, general reactions and what to do about them, and most importantly, parents should be told when they should seek professional help. Record keeping is becoming increasingly important with the more complicated schedule. Records should be held by practitioners as part of routine clinical practice, but also a parent-held record should be given to each child as it leaves the surgery for the parent-held record. In some places, this will be essential for enrolment of the child at school. So immunisation is a complex and increasingly complex procedure. There are going to be new vaccines in the future, and the changes that I've outlined just now are going to be followed by many other changes in the next couple of years. This will involve greater effort at all levels by the community, by all kinds of health professionals to raise our immunisation status. Especially in the country, nurses play a major role in the administration of vaccines, and so with that in mind, Desley will be presenting our first case.
Thanks very much, Robert. First case study, really, we've got Daniel, who's 4 months of age, brought in by his father for his second immunisation. He's well and on examination appears to be healthy. Mr. Smith tells us that Daniel didn't have any serious adverse effects from his first lot of injections. And so what we're asking you to do then is to look at the 6 questions that we've posed for you so that we can discuss those. This is just the sort of person, I think, the child that we would see routinely, Bruce, as a nurse or a doctor presenting to us.
Thank you, Desley. Thank you, Robert. We've arrived at the point in the programme for you to break off into your workshop groups. When we come back on the satellite in about 10 minutes, you will have the opportunity to put your questions to the panel. Many of the hospitals joining us for the first time tonight will not have a phone or a fax numbers for sending in questions. So here they are. Please write these numbers down and put them in a safe place, as they're the same for every programme. The phone number is 008 658 499, and the fax number is 008 061 273. So keep focused on the issues. We will be responding in detail to each of the questions that are raised in the case study, so please try to answer each one in the 10 minutes that you have. Okay, your 10 minutes start now. Good luck. Welcome back to the studio for the first interactive segment of our programme. We're going to put Moe, Gippsland, on the spot and ask them to give us their answers to the questions that were raised in the first case study. Tonight, however, we have online Bendigo, Coffs Harbour, Mackay, Moe, Taree and Townsville. OK, so we've given you a minute to get your thoughts together in Moe. Chris Lample, how did your group go with the questions in this case?
Oh, well, thank you for this terrific opportunity of talking. It was quite simple, actually, because in Victoria we have an interesting system where, in fact, the councils are responsible for that. So the problem was easily solved. Mr. Smith was told to go to the next council immunisation schedule to have it all done there. But, in fact, we did go a little bit further because we felt that we had to provide a service. The question number one, we gave them all the immunisations that you referred to earlier on. We asked Mr. Smith were there any reactions to his previous examination. The question was put here, was Mr. Smith in fact related to Daniel? Because in Moe we have certain difficulties in establishing the family dynamics. We were very impressed with there was the strong feeling that we should be giving Panadol. One of the members here is in fact an infant welfare maternal childcare sister, and she's very supportive in giving the Panadol before the schedule begins, and we think we've got the logistic support to do that. The storage of the vaccine, one of my colleagues, we got it right. I think she said in the fridge. We think that was a reasonable answer, but we did find that it was between 2 and 8 degrees centigrade in the top shelf of the fridge. Most of us do keep when the problems do front up for the occasional top-up, and we in fact do them in the clinic, we do keep our own records, but we think it's a little bit inadequate. I'm sorry, I've been a bit flippant with this presentation. In Victoria, in fact, it's very uncommon for the general practitioners in their clinics to do much of this, and most of the clinics, in fact, do not keep the vaccines. It's all done through the councils. Now, there may be some changes. Certainly in Moe, we've just been told we've merged into a greater council, and it is quite chaotic at the moment to find out what's going on in terms of whether there will be some changes made. It's probably more useful for the panelists to comment on this rather than Moe. But we have some questions for later on if we can come back to you.
Thank you very much, Chris. Margaret, do you think that's a fair assessment of this case?
Yes, I think that you did well down there in Moe. I guess the thing that comes up very often is whether this little 4-month-old child needs to be examined or not. Can you give him a quick look over from the end of the bed, so to speak, and say that he's well enough to be immunised? And I personally think that you can. I think we need to be sure that he hasn't had any reactions to his 2-month-old vaccines, and so that part of the history needs to be clear cut. Then we certainly need to give Mr. Smith, whether he's the father or not of this child, a little bit of advice about what to expect when he takes the baby home, that the baby will be irritable and maybe febrile, and to continue the doses of paracetamol, and certainly to get back to his medical practitioner if there's any problem that he feels worried about in the first 48 hours after the vaccination. So I think they did well in Moe.
Thank you. Rob, can you comment a little bit about the vaccine storage?
Yes, thanks, Bruce. Certainly vaccine storage is a major issue, and as you know, vaccines are temperature-sensitive things. Some of the vaccines are more sensitive to freezing, some of them more sensitive to heat. So storing them in that range between 2 degrees and 8 degrees in the fridge is actually quite an important thing to do. What I've got here on the screen is a picture of a fridge that's been well stocked with vaccine, and as you can see here in the body of the fridge, the vaccines are stored within the body of the fridge with plenty of air circulation around them to keep them within the temperature range. The other things that you notice is that there's no lunch, there's no beer in the fridge, but it is important that that a certain amount of thermal lagging be put into the fridge, and as you can see at the bottom here, there are bottles of cold water. In fact, these should be filling up the entire door space, so that should there be a problem with the power or whatever, then the temperature will remain stable for longer. Some of the other things that are important is it's very helpful to have a notice on the fridge saying, do you need to open it? Fridge works best when the door's closed, so only open the door when you need to take vaccines out. And similarly, a little notice on the PowerPoint saying, don't pull the plug out. A fridge obviously won't work if the plug's not in there, and just as part of that routine, it's a good idea if somebody in the practice is responsible for the fridge, checks it every day, make sure that it's working properly. One of the other issues that's quite important for a lot of practitioners around the country is picking up vaccines from vaccine stores at local councils or hospitals, or if in those services where they take vaccines out to the patients. And here you can see an esky that has been correctly packed for transport of vaccines, that there are coal bricks within the vaccines, and the vaccines are kept cold inside the esky.
Thanks, Rob. Desley, who do you think ought to give this child its vaccination?
Well, Bruce, I think the important thing is the child gets a vaccination. I think extremely important that the parent have a choice of going to the nurse or the doctor, and I think that I'm sure as all health professionals are concerned about the well-being of rural residents, it doesn't really matter. I mean, it doesn't matter who gives it as long as the child gets it.
Thanks. Chris Lample in Moe, I think you've got another question for us.
Yes, it was more generalised. I mean, we live in a medico-legal bind. Obviously, these infants are not sort of checked sort of routinely to see whether there's any seroconversion, and I guess I have an anxiety at some stage. If you take a hypothetical where a child that's had MMR develops some kind of terrible encephalitis, where does the doctor who's given the MMR and where does the council stand in terms of litigation? I know that's more of a rhetorical question, but it is a cause of anxiety. We can't cover every possible contingency, because if you sit down with the parents and you go through every possibility, they'll run off without being immunised at all.
I agree with those sentiments. Chris, Rob, would you like to just comment?
Just briefly, that there have been a number of developments in that medico-legal area, and I think that the basic principle is that the parents should be given enough information so that they can make a decision that they're comfortable with, so that you should explain to the parents what the common side effects of immunisation are, what the rare side effects are. If the parent wants to know more about these things, then you should explain. But you should also explain the consequences of not immunising the child, so that the parent is in a position to be able to make an informed decision.
Thanks, Rob. We have another call from Townsville. Dr. Dignam, are you there?
Yes, our group here had a question and would like the panel to comment on giving children in this age group hepatitis B vaccine.
Well, that's a big one. Margaret, do you want to start?
Yes, I'd be happy to comment on that. At the present time, our schedule doesn't recommend routine hepatitis B immunisation for all infants, although it is recommended routinely in the Northern Territory. What we are recommending, according to NHMRC schedule, is that at-risk children are given hepatitis B immunisation. That means all children of mothers who've been screened and shown to be antigen positive, and children who are born into households where there's an ethnic risk factor. That means that effectively about 20% of children at the present time are given routine hepatitis B vaccination. Now, the World Health Organization is recommending that routine hepatitis B vaccination be adopted by the year 1997 in countries at both low risk and medium risk of hepatitis B. Australia's a low risk country, but at the present time, we don't have any combined vaccines. So if we were to introduce hepatitis B vaccination, it would mean that children would all need to have 3 separate injections at each one of those first 3 immunisation visits. And we don't think that the evidence is there at the present time to show that that's necessary.
Thank you, Margaret. We have 2 faxes. One's from Dr. Hume at Roxby Downs. Both of these faxes relate to site of immunisation. Dr. Hume's questions are: 1, the opening shots showed the injection being given relatively low and in the arm. Would the panel comment? And 2, should the immune system not be evaluated prior to the injection? And we have another similar question from Tony Balston of Gendowie in Queensland. Could the panel comment both on the site and the route of administration of the immunisation as to its efficacy? For example, it was recently reported on TV that it is almost negligent to immunise in the deltoid region in children less than 12 months of age. Also, recommendations vary as to whether measles, mumps, rubella injections should be given subcutaneously or intramuscularly. Rob, would you like to comment on the site first of all?
Well, the current recommendations of the National Health and Medical Research Council essentially originate from the World Health Organisation, and we've been recommending that the anterolateral thigh be the site of choice for children under the age of 12 months. And the rationale behind that is that that's an easily accessible muscle of large bulk in children of this age. In older children, we state that the deltoid is a perfectly acceptable alternative, and basically the reason has to do with the size of the muscle with the age of the child. So there's a lot of perhaps needless argument about the site of immunisation. We certainly recommend the anterolateral thigh in young children, but in older children the deltoid is an acceptable alternative. I think what is important is that the buttock is really not recommended these days, and that one of the other sites would be generally preferred.
Was my immunisation too low in that picture, do you think?
I must say I can't recall exactly where it was.
The other question from Dr. Hume was: should the immune system not be evaluated prior to injections?
No.
Routinely, I think that that's not the case at all. The danger is always the live oral polio vaccine at the age of 2 months, whether that's being administered to somebody who has an immune defect or either a congenital or acquired immune defect. Most of those children who do have those defects will have evidenced themselves at that stage, and they are a very, very small proportion of the community, and certainly unlikely to be seen in any single practice lifetime. So the answer is no, they don't need to be serologically assessed, clinical assessment, and as long as the child is healthy, you should be free to go ahead with your immunisation. I think one of the other questions too, Bruce, was where the measles, mumps, rubella vaccine should be injected. Should it be deep subcutaneous or intramuscular? And the package insert, the manufacturer recommends that the MMR vaccine be given deep subcutaneous, and that's why it's in the NHMRC handbook, but most of us feel that it's equally effective if given intramuscularly.
Thank you, Margaret. I think we've got Tari on the phone. Dr. Trevor Banks. Tari, are you there?
Yeah, hello. Hello, I've got 2 questions. The first one is, if say the child turns up and hasn't had paracetamol, if you give paracetamol at the time of the oral polio vaccine, will it interfere with the oral polio vaccine? Second question, I know this is pointless, but what's wrong with immunising the buttock? Thanks a lot.
Thanks, Trevor. Desley, do you want to answer the first one about paracetamol?
Certainly, I think there's no problem. The idea is to either give it before, or if not before, then at the time. So it's not a bad idea to have some paracetamol in your surgery, and then to advise the parent to make sure that the paracetamol is kept up 4th hourly for the next 24 hours.
Margaret, I've heard you answer that second question about what's wrong with immunising in the buttock. Could you answer?
Yes, I'd be happy to answer the question about the buttock. I personally know that somewhere around 20% of medical practitioners and nurses are using the buttock. It's a relatively recent change, the recommendation to use the anterolateral aspect of the thigh. In fact, it occurred in 1988, so it is relatively recent. There are good anatomical reasons for not using the buttock, setting aside the possibility of injecting into the sciatic nerve, which I know that we all feel we wouldn't do. There's very much less muscle mass in the gluteal region in somebody who's not walking. So you're going to get a much better muscle mass in the lateral aspect of the thigh. And as far as local reactions are concerned to any vaccine which contains pertussis, it's very important to make your injection into the muscle. Any vaccine that leaks back subcutaneously or which is injected subcutaneously will give you a much bigger and nastier local reaction. So it's to all of our advantages to make sure that those pertussis-containing vaccines get into muscle mass. I think that that there was the question also of whether the paracetamol was going to interfere with the take of the oral polio vaccine. It's a question I've never been asked before, but I think on general principles it would be fair to say that it's very unlikely that giving paracetamol would interfere with the take of polio vaccine. It's a jolly high dose of polio virus that you're getting in that polio vaccine.
Thank you very much, Margaret. I've got an interesting fax here from Dr. Richardson of Bright in Victoria, which is a question that we've often heard, or I've certainly heard. The question is, with a polio vaccine, how do you recommend you give a single dose in general practice when it's presented in a multi-dose vial? Should we discard the vial after using it for one dose? Rob?
The cost of polio vaccine is actually in the bottle. The vaccine itself is extremely cheap to manufacture, and it's in the cheapest vaccine that we have on the schedule. What happens with polio vaccine once you open it is that when the air gets to it, it changes the acidity of the solution out of the fridge, so that this is an irreversible process. So the recommendation is that that polio vaccine should be discarded at the end of the session, that it should be normally stored between 2 and 8 degrees. In the immunisation handbook, there is a recommendation made about freezing of polio vaccine, but what practitioners have told us since that went to press is that in fact, domestic refrigerators can't get down to the kind of temperature that that makes that recommendation viable. So I think what we need to do is to store the vaccine between 2 and 8 degrees and to discard it at the end of the session.
Thank you, Rob. Desley, a fax from Karen Maguire, who is a director of a childcare centre in Mission Beach. What additional consideration should be given to a child attending childcare? My concern is there seems to be an emphasis on preschool immunisation, and I wondered how and when we can advise parents about the children at risk going to childcare.
I think the important issue here is that if the children are immunised according to the schedule, then there really is no extra risk. So it's a very good, I think, opportunity to educate parents about the importance of having that immunisation before school, so that they in fact don't forget to give it to them. So as long as the child has been immunised according to the schedule, not a problem.
I'd like to follow up on that. I think that it's very important for children who are going to childcare that, as Desley says, that they're at risk of the ordinary respiratory transmissible diseases, measles and pertussis particularly. So keeping up to date with the ordinary schedule on time is extremely important in this context. I know that a lot of people have asked me about the question of hepatitis B, for instance, in childcare, and as Margaret has pointed out, it's our view at present that there is no additional risk that would mean that children should be immunised against hepatitis B just by presence at childcare. But I think the major message is that the standard NH&MRC schedule is particularly important for children in childcare.
I'd like to also point out that Hib disease is 2 or 3 times more common in children who attend childcare than children who do not. So if you have any children in your childcare environments who haven't had their catch-up Hib doses, then it's very important that they do.
Thank you, Margaret. We've got Coffs Harbour on the line. Dr. Ladhani, Coffs Harbour, are you there?
Yes, thank you. We've got 2 questions here. One is regarding the use of paracetamol in cases where it is recommended in the handbook that if the patient has got a mild fever like 37.5, it would be quite in order to give the vaccines. On the other hand, we also advise the parents that the kids should have paracetamol to coming to the surgery or prior to giving the vaccine. Now, if you happen to check the temperature after the paracetamol and it is 37.5, what would you advise in this case? The second question we have is when we talk about transmission of, say, especially oral polio vaccine, I mean the transmission of polio in case of usage of oral polio vaccine, what is the actual incidence of transmission of polio in immunocompromised cases?
Thanks very much. A few questions there. Margaret, do you want to start?
Yes, well, I'd like to start. I think the first question was if a child comes in with a temperature of 37.5 for its routine immunisation and has already had a dose of paracetamol, what should you do? And I think mostly it will be pretty clear from the history whether the child was unwell this morning or not, and whether the mother thought that the child was febrile at the time that she gave the paracetamol. If she did, well, I would certainly ask her to come back again in a day or two when I'd give the doses that were due. If the mother felt that the child had been perfectly well all morning and was surprised when to find that the child had a temperature of 37.5, and if I could see just by looking at it that the child looked well, I would go ahead and give the triple antigen. The second question was the question about the transmission of oral polio vaccine. Oral polio vaccine is transmissible, and it is important to be sure that no household contact of the child who's being immunised does have any sort of immunodeficiency disease. The incidence of polio after oral polio vaccine is about 1 case in every 3 million doses distributed. It's less in the recipients than it is in contacts. So it is important to be sure that the parents of children who are being given oral polio vaccine are in fact immune to polio themselves. And you'll find in the NH&MRC recommendations a note to say that if you're unsure of the immunisation status of parents, and that can be the case particularly with immigrant parents, that you offer them a dose of oral polio vaccine when the child is being vaccinated. There were 2 cases of vaccine transmitted polio in the UK last year in parents, so it is important to make those, get that historical information about the family.
Thanks, Margaret. We were told when we were preparing for this programme that this half an hour will be the fastest half an hour we'd ever experienced, and it certainly has gone fairly fast. Margaret, can I just ask you to wrap up on the first case, please? Yes,
well, the first case, little Daniel came along with his father for his second doses of of immunisation. It was important to know that he was well, had he had any reactions to his previous doses, and important to make sure that he had a dose of paracetamol and that there were that he was advised, that the father was advised about doses every 4 hours for the next 3 or 4 for the next 3 or 4 lots of 4 hours. It was also important to know that those vaccines that you had in your refrigerator had been properly stored, both after you received them and before you received them. It was important to recognise the need for good injection technique, so that injection was made into the anterolateral aspect of the thigh in young children, and that all of these vaccines are given deep intramuscularly if they contain pertussis. And it was important to give advice about the side effects. And remember, Rob said earlier that page 22 in the Immunisation Procedures Handbook is that page which you've had given out to you in your pre-pack there, and that is a take-home page for parents to tell them about the incidence of minor side effects and what to do about them. It's also important to have a proper recording system to record the immunisation in the child's parent-held medical record and in your notes, or if the child doesn't come along with a parent-held record, that they at least go home with a paper or card with a record of that immunisation. It's also important to recognise the need for notifying adverse reactions to immunisations, and since the 1st of April, the Commonwealth Department of Health is asking us all to notify major adverse reactions. We don't expect there'll be very many, but we would like you to notify them, and state by state there are individual recommendations about that. The other thing is to start thinking about whether you're going to have a recall system, a reminder system. I think that there's lots of evidence now to show that it's a very good thing to do, to have a reminder system to get parents to come along at the right time for the next dose, so that we get good age-appropriate immunisation. Thanks, Bruce.
Thanks, Margaret. Would you like to go on now and introduce the second case for us?
Yes, the second case is just slightly more complex. This is a little girl who's now 13 months old, who comes along with her mother, and the story is that the mother has been in the local child health centre, and she's noticed that there's a poster on the wall about the need for measles, mumps and rubella vaccine at the age of 12 months. So she realises that little Tiffany hasn't had that vaccination and comes along for the vaccination. She's new to the district, and so she has to give some history to you about the child, and also you discover that the child hasn't had the Hib vaccination. And when you go off to the fridge to get the vaccines, the mother says that she's noticed that there's not much measles and mumps around these days, and are these vaccines really necessary? She's also saying that she's heard from one of her friends that a child who had been vaccinated for measles in fact developed the measles some 6 months later. And so we'd like you to address the questions there on the case and get back to us with your answers.
Thank you, Margaret. We'll be back then in 15 minutes to put one of our hospitals with a direct link right on the spot, so be prepared. Goodbye for now. Welcome back again. We're going to ask you, Dr. Rani and Mackay, for your group's response to the second case. But before we do, just a reminder to please keep those questions coming. We'll make every effort to get as many as we can answered tonight. Okay, to kick this session off, it's over to you, Dr. Rani.
Concerning the first question, I would suggest that there has been a lot of measles and mumps around the region all the time, and it is important now that she has made the effort of coming to the clinic to have the injection? And for the second question, to inquire about the allergies, and there could be a reaction like an anaphylaxis reaction, and to have the adrenaline and resuscitation gear ready if there is any suggestion of allergy to eggs. And in immunocompromised people, we may have to do further investigations like assessment of immunoglobulin G, particularly if there has been a history of very frequent intercurrent infections. And also, if the mother has been not rubella positive antibodies when she was tested in her antenatal care, and if she is pregnant now, and if the child is to have vaccination, then the mother might get the rubella infection herself, and particularly if she is in the first trimester. And in regard to the third question, what would you, if Ms. Johnson didn't have Tiffany's child health record, according to the history, she already has brought the health record, but we would probably photostat copy and give it to her to pin on to the health record, and we will mention it on our chart so that next time she comes, we check that it's completed, and we will complete it for her if it hadn't been done. And in regard to the fourth question, there has been some confusion. Possibly she needs only one dose of Hib, and then later on at 18 months, it was a controversial issue whether to give two or just one, but she will be due for the DTP at 18 months, and then again at 5 years pre-entry to school, along with the oral polio vaccine. And the fifth question, if she did have a sore leg, we would suggest to the mother to give some Panadol for that, and it shouldn't really deter her from further vaccination. In regard to the sixth question, we would advise the mother regarding her next dose of the immunization when she brings the child for the postnatal checkup, and write it down, her the date exactly when the doses are due, and advising her to come. And if we do have a recall system, we would send out the recall reminder to the parents. Thank you. And I would like to ask two questions before I finish. One is, if the child has had oral polio vaccine, is there any concern of intramuscular injections within a month of the oral polio vaccine? And also, could you please comment on BCG vaccination on infants? Thank you.
Thanks very much, Dr. Rani. There's a lot of very important points, I think, you've brought up there, and perhaps I could ask Rob to comment on some of those.
Yes, thanks, Bruce. It sounds like you've had a good discussion up there in Mackay. Certainly, the way that I view this is that you're right in that the mother's made the effort to come. So I think explaining it all through and taking a very sort of personal interest in the mother, then that is the way to ensure that the child receives the vaccine, and that the issues that the mother raises should be explained to her. You raised the question of allergy, and particularly egg allergy, and this has been a somewhat vexed subject with regard to MMR. The current opinion is that children who have true egg allergy, and this is very uncommon, and what we're talking about is an anaphylactic kind of response to egg, they can still be frequently immunised under appropriate conditions, and a number of places have, for instance, set up special clinics based in children's hospitals and so forth where this can be done. So I would not give up on a child who had a history of egg allergy, even if it were a history of severe true egg allergy. You mentioned the question about rubella transmission. If the mother has not been immunised against rubella prior to pregnancy, then that's an issue that needs to be dealt with, and that women should have their rubella status checked before pregnancy, if at all possible. The rubella vaccine is not transmissible, so that immunising the child does not pose a risk to the mother. I agree with you entirely about with your strategy of giving a photocopy of the record to the child. I guess my view is that children should not leave without a record once they've been immunised, so that some form of record should be given to the child to take away. The National Health and Medical Research Council, with regard to the Hib question, does recommend that children of this age should get a booster dose at age 18 months. This is using the commonly used vaccine, the Hib-Tita vaccine. And I agree with you about following up with the normal 18-month and preschool doses. I think the question about the sore leg, this, as you say, can be ameliorated to some extent by paracetamol. But as we've discussed earlier in this program, it's very important to ensure that injection technique is as good as possible, because, as Margaret has mentioned before, that if there was inadvertent injection to other than intramuscular, then you can get an increased rate of adverse events. So I think that with regard to those questions, that you seem to have had quite a good discussion up there.
Thanks, Rob. There was one other I'd like to ask Desley, which is the sixth one.
Okay.
What strategies would you use to promote immunisation in your practice or clinic?
Right, thanks, Bruce. I think one of the things that's really important is that's coming up to be a very big point is the missed opportunities. You know, that when children present to the clinic or to their surgery, that you do check to make sure that their immunisation is up to date. I think that's extremely important. That's something you can do very easily in as part of your normal practice. You mentioned recall systems, which I think is very important, and we've seen how effective they can be, and they're not all that expensive to run. But once again, I think I should reinforce the fact that I think it's important that nurses and doctors have the same recall system rather than it being duplicated in one area. The other opportunity is antenatal classes, that if you're running antenatal classes, it's a wonderful time, and even before women go home with their babies, it's a good time also to give them an immunisation message, so that you're being very proactive in your role. Posters and pamphlets can be used, but you have to be careful there, of course, that you change them around, otherwise they become part of the furniture and nobody notices them anymore. And the other thing, of course, is just if you're a nurse, then maybe you can do some health education and promotion down the street, just to try and re-educate people about the fact that these diseases are serious, because I've found myself that people quite often don't really know what the diseases are anymore.
Thanks very much, Desley. There were two other questions that Dr. Rani had. One was, I think, should polio, the oral polio vaccine, be given within a month of another intramuscular immunisation? And the second one was, could we have an update on BCG? Margaret, would you like to comment on those?
Yes, Bruce. The question of intramuscular injections following oral polio vaccine has been looked at recently. It's important to remember that the incidence of polio after polio vaccination is extremely remote. 1 in 3 million doses issued. It hasn't occurred for years in Australia. But there is a study to show that repeated intramuscular injections after polio vaccination may increase very slightly the risk of vaccine-induced poliomyelitis. As far as BCG vaccine is concerned, it's very rarely indicated in normal urban children in Australia. It is sometimes given in rural Indigenous children, and it's certainly indicated in children in a household in which there has been an active case of tuberculosis, but very rarely is BCG given in Australia these days.
Thank you, Margaret. We've got a fax here from Mary Adams of Edenhope. Mary asks, the child after 12 months of age, if requiring catch-up immunisation, should there be 18 months between injections to reduce the side effects of the triple antigen? Perhaps I could ask Rob both to address that specific question and perhaps give us an overview of catch-up immunisation.
Yes, I think that one should just continue with the normal intervals between immunisations. If you have a child who has fallen behind for some reason or other, then it's important to catch up as soon as possible, and there's no evidence to show that spacing out the immunisations further than the normal recommended doses reduces the incidence of any adverse events. The question of catch-up is very important. As we've heard, the level of immunisation in Australia could be brought up quite considerably, and so that means that there are a lot of children who could benefit from having their immunisation courses being brought up to date. So I think that this is something that ought to be reviewed every time a child attends for a consultation, so that any immunisation delays are minimised to as short a time as possible.
I think also, as far as catch-up is concerned, it's important to remember that you can give those missed vaccines simultaneously. So in certain circumstances, for instance with recent immigrants or children who have escaped the healthcare system for a period of time, and they come in over the age of 12 months perhaps with possibly only one vaccination having been given, it is quite possible and acceptable to go ahead and give the measles, mumps, rubella vaccine and the Hib vaccine and the triple antigen and the polio vaccine all on the one day, and it would, under some circumstances, also be acceptable to give the hepatitis B at the same time. The vaccines will all work quite adequately. They won't interact with each other. They'll all work just as well as if they were given separately, and the side effects won't be potentiated by a co-administration of those vaccines. They have to be given at separate injection sites, but you can catch up that way, and in fact in the United States schedule at the age of 18 months all of those vaccines are recommended at the one time.
Thank you very much, Margaret. We've got Chris Lample on the phone again from Moe. Chris, you have a question for us.
Dr. Robert Hall here from Moe. 15 years ago in Victoria we identified that even though measles vaccine was less effective before 15 months, the mums disappeared from the infant welfare system around about 12 months of age, and so we decided to do the shots at 12 months so we didn't lose the kids. Now, why not add the MMR to the 18-month vaccination to simplify the schedule and reduce a visit if that's the... now we've got Hib in the system. We've got a second question to do with monovalent pertussis vaccine. It's been recommended this is suitable up to 8 years of age now. Is monovalent pertussis available, or if not, can we use DTP, and would that have any problems?
I'd be happy to answer those, Bruce. We think it's very important that measles, mumps and rubella vaccine is given at the age of 12 months because more and more where we're seeing outbreaks of measles, we're seeing children under the age of 12 months getting measles. Now that's the very high risk group for developing a subacute sclerosing panencephalitis. Basically, the earlier you get the measles, the more likely you are to get SSPE. So we're very keen to have measles vaccine, measles, mumps, rubella, given at the age of 12 months. And as more of our mothers become vaccinees, then children are going to become susceptible to measles earlier and earlier. And it's my prediction that we may even get a schedule which introduces measles, mumps, rubella vaccine at the age of 9 months in the future, as Robert's been talking about schedules in the future. Monovalent pertussis vaccine is available. It's produced by Commonwealth Serum Laboratories. It's mostly not provided by the vaccine distribution centres, so you need to write a prescription and get your local pharmacist to get it in for you. But it is available, and you should be in touch with CSL about that. It's not advised to catch up with DTP. If you have a child who's had the required doses of diphtheria and tetanus, if the child's had 3 or 4 or maybe 5 doses of diphtheria and tetanus, if you give more DTP, you're likely to get nasty local reactions because you're over-immunising for diphtheria and for tetanus. So it's advisable under those circumstances just to use the monovalent single-dose pertussis vaccine for catch-up. Thanks.
Thank you very much.
And I've heard a lot about this other mysterious Dr. Robert Hall.
We're getting lots and lots of faxes coming in, so could you be nice and concise with them, please? It makes them easier to answer. I have one here from Dr. McGovern in Maxville. Is pertussis vaccination contraindicated if the child has previously had pertussis? Can I ask the real Dr. Hall?
I'm not so sure about the real one. I'm sure there are many. Pertussis vaccine is not contraindicated if a child has had pertussis, but children over the age of about 2 years, if they've had pertussis, will develop an immunity. So giving subsequent doses of pertussis vaccine is not necessary. So if a child has had a real infection with pertussis, and this needs to be confirmed, then they will develop a natural immunity. But obviously the aim of the exercise is to try to prevent this from happening in the first case, so that age-appropriate high levels of coverage would be the way to prevent that.
I think perhaps people are sometimes concerned that if there may have been a history of pertussis, that if you give a pertussis vaccine you'll get a bigger local reaction or a more energetic systemic reaction to that vaccine. There's no evidence that that occurs at all. So if you're unsure of whether the child has had pertussis or not, if it hasn't been microbiologically proven, then it's best to go ahead and immunise the child and make sure that he's protected from pertussis.
Thank you. We've got Townsville on the line here. Dr. Dignam?
Yes, I have 2 questions for the panel, please. Could the panel address this case scenario? A child is on some low-dose antibiotics for example, a chronic ear infection. The 12-month immunisation is due. Should they be given while the child is still on antibiotics, or should the antibiotics be suspended? And the second question is concerning the oral polio virus. Could you just clarify the point? Suppose, for example, you ask the parent whether they are immunised and they say no, you could give them the oral polio virus immunisation. If the parent happens to be immunocompromised, what action would you take? Thank you.
Thank you, Dr. Dignam.
I'd be happy to answer those, Bruce. The question of low-dose antibiotics, they are not a contraindication to giving the immunisations, either the polio vaccine or the triple antigen or any of the other immunisations. They won't interact. As far as the child who's having oral polio vaccine and the parents, it is important to know that the parents have been immunised. If they haven't and they're not immunocompromised, commence them on a course of oral polio vaccine. If you do have immunocompromised household contacts of a child who's due for polio, then the child should be given inactivated Salk-type polio vaccine, and that again is able to be got from Commonwealth Serum Laboratories. So polio vaccine by injection.
That brings us on to another question, Margaret, from Philip Buckel in Armidale. Good evening, Phil. In some provinces in Canada, Salk is given instead of Sabin. Ontario is one. Could you comment on the reasons why?
Yes, there is a tendency now to be thinking about vaccine-induced poliomyelitis, particularly in North America, where they have about 10 cases of polio a year, and half of those are due to vaccine, with the idea that we develop a sequential schedule so that the first couple of doses are inactivated polio vaccine followed by a couple of doses of oral polio vaccine. I don't think we'll have that in Australia in the next little while, because inactivated polio vaccine is very expensive to make and it's not easily available. So it's quite likely we'll have worldwide eradication of poliomyelitis in the next few years.
Thanks, Margaret. Tari on the phone. Dr. Trevor Banks.
Oh, hello. I've got two questions. The first one is to Rob. He mentioned that Tiffany should have HIV vaccination at 18 months. Should she also have HIV vaccination at the same time as her MMR? Second question, I've forgotten. The first one will do, thanks.
Yes, thanks. This just reinforces the point that we've been making, that simultaneous immunisation, if at all possible, is something that we strongly recommend. So to minimise the time that children are left without protection. So give MMR and the first Hib dose at age 12 months, followed by the second Hib dose at age 18 months.
Thanks, Rob. I've got a question from Dr. Chamberlain in Rockhampton. The MMR recommendation for the teenagers is now on the schedule. Parents still have to pay unless this is a primary vaccine. Is there any immediate change in sight? Does anyone know the answer to that?
Well, I can give some answer to that. Many states are operating the MMR program as an extension of the rubella schoolgirl program that's been operational for many years. And I must say, I thought that that was how the MMR was given around the country.
Thanks, Rob. We've got Bendigo on the phone. Dr. Devidas.
We've got a simple question. What is the absolute contraindication for any or all the vaccinations? In case of a family member on a immunosuppression or chemotherapy, can we give baby Sabin and isolate the baby or the family?
Margaret.
I'm happy to answer that. No, you can't give Sabin and isolate the baby. The baby may excrete Sabin vaccine for weeks and weeks. The only acceptable thing with a household immunosuppressed contact is to use inactivated polio vaccine.
Thank you, Margaret. That was a nice, precise answer. Dr. Ram Buckwell of the Logan Hospital in Brisbane. What is the incidence of anaphylactoid reactions to injectable vaccines?
We were just discussing this before we went to air tonight, and amongst us on the panel, we weren't aware of any reports that had come to attention of anaphylactic or anaphylactoid reactions. But given that we're not aware, you still need to take precautions against this very rare event occurring. So as part of normal immunisation procedure, your setup should be that you have the appropriate drugs available to counter anaphylaxis.
I think it's important to point out that you're more likely to get anaphylactoid reactions in adults who have had multiple doses of tetanus or diphtheria vaccine, that it's relatively unlikely that you'll get anaphylactoid reactions in the primary courses that we're talking about in infant vaccination, but it certainly does happen with tetanus. I know from personal experience.
Thank you, Margaret. We've got a letter from Ararat, Dr. Mac Isaac. I'm sorry that we haven't answered the previous faxes you sent through, but you've been very persistent. Thank you. The answer is, can we give the first vaccine group at the 6-week postnatal visit rather than the proposed, the scheduled 2-month visit?
Bruce, that it's probably better to wait for the 8 weeks. We've talked about that. This is something else we talked about too, is maximising the opportunities, but it's probably better to bring them back at 8 weeks. What do you think, Rob?
Yeah, there are always compromises that you have to make with immunisation schedules, and you have to weigh up the response as against the feasibility of parents bringing their children in. So the current view is that the best compromise is 2 months for the first dose.
Thanks. Tyree on the phone. Dr. Banks.
Hello, it's Dr. Cook here, actually.
Oh.
Question is in relation to vaccination into the buttock, bearing in mind that you may only vaccinate with DTP into the intramuscular area, can use the others into subcutaneous tissues. Is the buttock excluded for using those other vaccines?
Dr. Cook, the buttocks always excluded for hepatitis B vaccine, both for infants and for adults. We have good data to show that it doesn't work as well. Hepatitis B vaccine does not work as well if it's given into the buttock. Now, there's no data on seroconversion rates for any of the other vaccines according to site. In other words, we don't know whether it works less well for the other vaccines. What we do know is one study only from the United States suggesting that reaction rates are slightly less. Local reaction rates are slightly less in the buttock, but systemic reaction rates are about the same whether you use the buttock or the lateral thigh. So bearing in mind the anatomical questions, the recommendation I'm sure will stand that we use the lateral aspect of the thigh in infants.
Thank you. Another fax from Dr. Drowan in Wangaratta. If you've got a child that didn't get their 18-month vaccination, which was actually done at 3 years, do you still go ahead and give the DTP at 5 years as recommended? Rob?
You do. Basically, the schedule, you never step back with a schedule that children who have not completed the schedule, once they have been brought up to date with the doses appropriate for their age, they then progress on for the continuation of the course.
Thanks, Rob. Coffs Harbour on the phone.
Oh, hello. I've heard that adults who have bone marrow transplants have to have their entire childhood vaccinations recommence. Is there any other situations where you think of that in later life?
Well, there's always children who've had bone marrow transplants, and the same thing applies with them. They need to have their vaccinations recommenced. It does depend a little bit on whether the donor, how immune the donor was, because the bone marrow transplant person picks up some immunity from the donor. But it's only in transplant situations that you require to start again.
Thanks, Margaret. Louise Baker from Cowra. Good evening, Louise. Her question is, what is the immunisation of choice for Aboriginal children against HIV, and what is the schedule? I think, Rob, you talked about this a little bit earlier on.
For Aboriginal children, they have a somewhat different picture of invasive Hib disease as compared with non-Aboriginal children. And the vaccines that are recommended reflect this. Aboriginal children tend to get disease at a younger age than non-Aboriginal children, and so we recommend the use of PEDVAX Hib, where the schedule is completed earlier for Aboriginal children, whereas for non-Aboriginal children it doesn't really matter which of the vaccines are used, and the current major supply just happens to be Hib-Teta. So for Aboriginal children the recommendation is the use of PEDVAX Hib, which gives a response more appropriate to their epidemiological situation, and for non-Aboriginal children we currently use Hib-Teta.
Thanks, Rob. A question I might ask Margaret. This is from Dr. Peter Christopher at the Bathurst Base Hospital. In Australia, are we likely to have available the combined triple antigen Hib vaccine, i.e. a quadruple antigen in one syringe, as used, for example, in parts of the USA?
Well, we certainly hope to get that vaccine into Australia. The triple antigen HIV vaccine's been used now for 2 years in the United States. There are some licensing problems regarding the vaccine because it's made up according to the US requirements, and Australia likes vaccines to be composed according to the British Pharmacopoeia. There will be multi-dose, multivalent vaccines, I'm sure, in Australia in the next 5 years. At the present time, a vaccine which contains all 5 agents, diphtheria, tetanus, pertussis, Hib and hepatitis B, is on trial in Australia, and the seroconversion rates are being tested. So within the next 5 years we're going to have multivalent vaccines in Australia.
Dr. Ramswamy in Cobar, with regard to polio vaccine, what is the recommendation about boosters in adults and how often?
The current recommendations for polio boosters in adults are that it's not necessary unless they are being exposed, generally by virtue of travel to countries where polio still exists. World Health Organisation is trying to eradicate polio, so this situation may change in the not too distant future. But the current recommendation is that adults who are travelling to countries where polio is still endemic should receive a booster every 10 years.
Thanks, Rob. We've only got time for one more fax. We've actually been inundated with questions here, and the panel discussed at the break that we would like to try and, or they would like to try and respond to these questions. So we'll attempt to provide answers to as many of the questions as we can and distribute them in the next Rural Health newsletter. For the final question, Pam Colden of Edenhope. Margaret, perhaps you could answer, is it common that there is a reaction following the second rather than the first triple antigen?
Well, I think it varies very much. You know, sometimes you'll get a reaction after the first dose, they'll be okay after the second, and they'll get a reaction after the third. But in general, provided vaccine injection technique is okay, if you have had a local reaction, then those local reactions tend to repeat themselves and sometimes to be slightly more severe, whereas the systemic reactions tend to get less with increasing vaccine dose. So there is the likelihood, if there has been a previous local reaction, that there will be one or the same or even a little bit bigger with the second dose.
Thank you, Margaret. Robert, do you think you could give us a wrap-up for that final case, please?
Thanks, Bruce. As we've seen with the discussion, this case brings up many issues, and there are lots of complexities involved. So I'll just talk about a couple of the things that strike me about this case. The first is that this child has moved, and these children are at risk, and that we need to take special efforts to try to find children who, for one reason or another, are at higher risk than others for slipping through the net, if you like. The second issue that I think that it illustrates is the progress with Hib vaccine, that this child is due for its Hib vaccine, and as we've discussed before, this is one of the really exciting things that shows what can be achieved with immunisation. The third issue, I think, is perhaps a little bit more complex, in that Tiffany's mother is a little bit ambivalent about the question of immunisation, and needs some discussion about what immunisation's all about. One of the things that's important is this question of vaccine efficacy. How much protection does a vaccine give? And this is one of the questions that this parent has particularly asked. What we have here on the screen is various results from field trials and from observations made during epidemics of how much protection you can expect from vaccines that are used in the current schedule. so that you can see that there is substantial levels of protection that is afforded by modern vaccines against these diseases. And I think it's important to discuss this with patients, particularly with parents who may have some doubts about the value of immunisation. And what I find is perhaps one way of explaining to parents is that they say, well, as Tiffany's mother says, that I know of children who have been immunised yet still have the disease. And I think that one way of explaining it to them is to say, well, in fact, the way that you have to look at this is to compare what happens with a child who's been immunised as compared with a child who has not been immunised. And the figures that, that I've just shown are basically derived in this way, so that there will be a small proportion of children who will develop diseases despite immunisation, but overall, immunisation offers very high levels of protection against the diseases. So I think those are the major messages for me.
Rob, one very final question. Can we mix Hib vaccine with triple antigen and give from one syringe?
With currently available vaccines, no, we can't. There are technical difficulties with mixing the vaccines in the same syringe, and it is very important not to do this. It's important that children should be immunised with those two vaccines being given on the same day, if they're due on the same day, but they should be given with different syringes in different sites.
Thank you, Rob. Well, where do we go for further information? The Immunisation Procedures Handbook really answers, I think, virtually every question about immunisation. There's a very easy to use, user-friendly index, and something that I only learnt in the last few days was that the pale green pages, which are the second chapter about the standard childhood vaccination, really tell us almost all we'll need to know about the standard schedule. If you'd like to order a copy of this book, you can fax the order form into us, and the package will be sent to, if you fax it to the Education Unit, AIDS and Communicable Diseases Branch, Department of Health, Human Services and Health, and the fax number is 06 289 6838. If the book doesn't help, or there are some other problems, I think you can approach your local public health unit, or your nearest public health unit, I should say, or a paediatrician who you know has a specific interest in immunisations. But I can't stress enough, I think most of the information is available here. Margaret, would you like to summarise what you think we've learnt from this evening?
Yes, well, I think, Bruce, the take-home messages from my point of view are how important it is to use every opportunity to take an immunisation history and to update the child's immunisation on the spot. In other words, to use those opportunities. We are in Australia 26th out of the 28 developed nations in our uptake of measles vaccine, and the only way we're going to catch up is to use those opportunities. And we also have discussed in some detail the way that we can give immunisations simultaneously, not mixing them as Rob has pointed out, but giving them by separate injection, but they can be given on the one day. So I think that's a very important take-home message. The other important take-home message is the use of paracetamol. We know that minor reactions to pertussis vaccine are quite common. We know that they will be reduced by 50% if you use paracetamol at the time of the vaccination and then for 3 or 4 doses afterwards. So that makes a tremendous difference to patient and parent acceptability of pertussis vaccine. I think that's a very important take-home message. The other thing that I think we need to emphasise yet again is the importance of injecting those vaccines into muscle. You'll get far less local reactions if they're given carefully intramuscularly. So they're my top 3 take-home messages for tonight.
Thanks, Margaret. Rob?
For me, I think that there are 2 major messages. Coverage, I think, is extremely important, but not just maximising the number of children that we are able to protect with vaccines, but ensuring that this is done on time so that children don't spend time exposed unprotected to disease. So I think age-appropriate high levels of coverage are extremely important. And I think allied to that is the second thing that I think is really important with this issue, and that is the communication with parents. And I think that being straight and enthusiastic, but with all of the facts with parents is going to be one of the major keys in improving our level of performance. And I think that this is an area where particularly rural GPs can make a great contribution.
Thank you, Rob. Desley.
One of the things that I think is important, and it comes, it links in with what both Margaret and Rob have said, is the importance in those states where there is more than one immunisation provider to try and have an integrated system, so that you're looking at a population register that both nurses and medical practitioners can access easily. I think the other thing is the importance of reminder systems. There are some that have been very successful. I think it's extremely important that we start looking at this. The worry always is that people might think it's Big Brother, but in fact I think we found, Bruce, that that wasn't a real problem at all in the one that was established in Armidale. I think what's really important and interesting is, I remember someone saying to me once, you may have a dog, for example, that and there's a overlay coming up here. You can see the little boy and the dog, and it's more likely, the way we are in Australia at the moment, the dog, particularly a pedigree dog like this, is up to date with its immunisation. The vet sends out reminder systems, but the child is more likely not to be fully immunised. So I think that, to me, is a very big take-home message.
Thank you very much, Desley. I'll remember to get my dog immunised. To me, the main things are that real contraindications to immunisation are pretty rare, and there's no reason why we shouldn't give immunisations simultaneously. So we should use those opportunities to deliver immunisation to our patients whenever we can. Good. It just remains for me to thank all the panel for the hard work they put into this evening, and Margaret, Robert and Desley, thank you very much. And thank you to our sponsor, the Commonwealth Department of Human Services and Health, especially Michaela Colburn and her supporting staff for making this event possible. Well, we really are out of time now, so it's good night from all of us here in the studio.